So, good evening, participants. So, we'll be discussing approach to neuromuscular weakness in critical care units. So I'll be basing my discussion on a case, and which we can discuss when I approach to a case. We'll discuss about pathophysiology and risk factors. We'll also discuss the neuroelectrophysiology and some of the etiologies of ICU-associated weakness. We'll discuss about the recovery patterns and what will help the recovery and how to prevent. And we'll end up the talk by giving an algorithm and conclusion. So the case starts like this, and it's a 51-year-old gentleman was admitted in ICU with respiratory failure. Known case of COPD since last 5 years, and alcohol dependency. 15 years ago, he had a major manic depressive psychosis. 3 days prior to admission, he developed low-grade fever and his dyspnea worsened. The ABG showed a partial pressure of oxygen 67 and carbon dioxide 67. It's increased. The pH is 7.28, temperature 37.7 degrees centigrade. This is tachycardia and normal blood pressure. Then on auscultation, there are bilateral views, and the PCV is 47. The WBC count, as you can see, is infection indicator. The platelet count is 321,000. Phosphates are 5.8. Chloride is 97. Other blood chemical values were normal. So methylprednisolone 60 milligrams every 6 hours. Derifulin, cefuroxime, and pantoprazole were given, and haloperidol, lorazepam, and aerosols of albuterol and epinephrine were also administered in acute care setting to control the delirium and other things. Starting on the 12th day, the dose of methylprednisolone was gradually tapered. 5 days later, amphotericin was also administered because of aspergillus pneumonia. After 2 unsuccessful attempts at extubation, a tracheostomy was performed on the 22nd hospital day. Tracheostomy was performed on 22nd. 27th day, methylprednisolone was replaced by prednisolone. Pneumonia developed in the right middle and right lower lobes on 31st day. On 34th day, the patient was very weak. On examination, he was alert, followed commands, bilateral ptosis, slight weakness of the right horizontal gaze, bilateral facial weakness, weakness of neck flexors, and flaccid tone in arms and legs. Strength in the arms was minimal to absent. There was wasting of the legs with minimal to absent muscle strength and absent tendon reflexes. The sensation of light touch, vibration, pinprick was intact in the arms and legs. The CSF was acellular, and the protein level was about 48 milligrams per deciliter. The glucose level was 100 milligrams per deciliter, and serial creatinine kinase values were recorded. I'll show you in the figure. So the nerve conduction studies and an EMG examination were performed on 34th day, and another examination was done on 78th day. And you can see the serial CPK values, which will tell the main. So this is the hospital day, and you can see the same CPK values are like this in this case. And the nerve conduction studies on 78th day, which is done left arm and leg. All nerve studies were in the left arm and leg. Median ulnar, tibial F waves were absent. RNST of the median nerve recording from the abductor pollicis brevis was normal at 3, 5, 10, and 50 Hz. EMG showed no abnormal spontaneous activity. There were many brief polyphasic MUAPs with early recruitment, and you can see the latencies are all in the normal range, and the amplitudes are also normal range. So it's slight reduction on which. So although the indication for mechanical ventilation was mainly bronchospasm, diaphragmatic weakness may have contributed to the respiratory failure. So that's another thing which we have to. The decreased tone, the reflexes, the areflexia, muscle atrophy, along with the generally normal mental status, absence of pathological reflexes, they suggest a neuromuscular disorder in this case. But there are difficulties in assessment. The CNS disorders may be difficult to rule out as the cause of acute weakness in this patient in ICU setup, particularly when the neurological examination limited by the inability of the patient to communicate or cooperate fully. The distinguishing between the lesions in the UMN and those in the lower motor neuron solely on the basis of physical signs is perilous, since acute injury to the UMNs can be manifested by transient flaccid weakness and hyperreflexia, as we all know. Thus, imaging studies may be necessary to rule out UMN disease if you are not comfortable. Oh, not visible. Why? Okay, let me see. I'll just have to go back and uh, is it visible?
Yes, sir.
Okay, thank you. Right. Science. Okay. Sound. So this we have seen now. Now let's see the neuro interpretation of what has happened in the electrophysiology in this case. And the initial motor conduction study showed low amplitudes, marked prolongation of the CMAP without severe desynchronization of the compound waveforms. The distal latencies, conduction velocities were normal. F responses were of normal latency and low amplitude. Later, as the muscle strength improved, the amplitudes gradually returned to normal with the gradual correction of the dispersion of the compound action potentials. The snaps were all normal, as were the blink reflexes. EMG showed no evidence of spontaneous activity. Assessment of the recruitment pattern showed no evidence of neurogenic disease, since the firing frequency of motor units was consistently normal. A full recruitment pattern was readily obtained. The MUAP potential ranged from normal configuration to polyphasic. Finally, RNST performed in the distribution left median nerve at stimulation frequencies between 3 to 50 showed no pathological decrement or incremental response. And okay, right. Now, so we'll just go slowly getting into the now. The salient feature of the EPS studies in this patient is the presence of low amplitudes, well synchronized, prolonged compound modal action potentials with normal distal latencies, normal conduction velocities, no evidence of conduction block in the segments of median ulnar nerves between the elbow and the wrist or the tibial nerve between the knee and ankle. The low amplitude CMAPs may be caused by the loss of motor neurons, their axons, or both. The distal conduction block in the motor nerves, blockade of neuromuscular junction transmission, are myopathies. All these things can cause the low amplitude compound muscle action potentials. The clinical features of the principal neuromuscular diseases causing acute generalized weakness in critically ill patients requires EPS study, also pathological findings, which I'll show you. So let us look at the differential diagnosis. What are the things which we can come across? The neuropathies first, myopathies, and neuropathies, neuromuscular junction abnormalities, and then the myopathies. The GBS is the most common cause of acute non-traumatic paralysis. typically occurs 1 to 3 weeks after an infectious illness, usually respiratory or gastrointestinal, but may also follow surgery or trauma. It is very important to recognize because immunosuppressive therapy is available for us and improves the outcome. In this case, GBS is a plausible diagnosis because the rapid evolution of weakness, greater involvement of motor, then there is no sensory involvement in this with areflexia, and possibly an infectious prodrome in ICU. The protein level in the CSF is usually elevated, but may be normal during the first several days of the weakness. Usually it ranges after 10 days. EPS finding in this case do not implicate any demyelination, paranodal demyelination, or the interaction of the humoral factors with ion channels at the nodes of Ranvier, which may produce conduction block, or which may be predominantly or exclusively distal without a substantial slowing of the nerve conduction. So we can GBS is unlikely in this case, though we have considered differential diagram. But the one variant is called acute motor axonal neuropathy. So acute motor axonal neuropathy is a variant of GBS and is caused by destruction of the motor axons. Also deserves consideration. This disease is manifested by acute onset of generalized weakness and areflexia. And again, same like GBS without sensory deficits, may follow exposure to Campylobacter and has a relatively poor outcome. There may be increased frequency of serum anti-GM ganglioside antibodies. The axonal variants of GBS syndrome that resemble acute motor axonal neuropathy have been reported in Western Hemisphere, but not very much in Indian subcontinent. The characteristic EPS findings include a reduction in the amplitude of the CMAPs, normal distal latencies and a conduction velocities, absence of conduction block, normal sensory action potentials, abundant abnormal spontaneous activity on EMG within days after the onset of weakness. Only abnormality that, as you notice, in axonal variant is amplitude reduction in CMAP. This case, which we are discussing, the absence of abnormal spontaneous activity in the 2 EMG studies done with the second study performed 6 weeks after the onset of the weakness, makes this diagnosis highly improbable because in axonal variant, you require spontaneous activity on EMG. So other things that comes into diagnosis, differential diagnosis, critical illness polyneuropathy. In patients in the ICU, a sensory motor axonopathy caused probably by the inadequate perfusion of the peripheral nerves in a systemic inflammatory response syndrome that results from sepsis, surgery, trauma, or burns. Systemic inflammatory reaction of the response syndrome, this alters the perfusion of the brain and other organs, and critical illness polyneuropathy is usually associated with encephalopathy also and multi-organ failure. So there are some characteristics of this illness which how we can diagnose. There's a depression in the amplitudes like CMAPs without abnormalities of any other abnormalities in nerve conduction. Amplitudes of snaps are also diminished, reflecting the concomitant loss of sensory axons. Abnormal spontaneous EMG is usually apparent within at least 3 weeks after the onset of symptoms. What is in this case? In this patient, this disorder is ruled out as the primary diagnosis by the presence of normal snaps in the first study, absence of spontaneous EMG activity as long as 6 weeks after the weakness began. So polyneuropathy, there may be myopathy, but polyneuropathy is not considered in this case. What else comes into differential diagnosis? Acute intermittent porphyria. So we've seen GBS, axonal variant, attacks of AAP and autosomal dominant disease are characterized by abdominal pain, psychiatric disturbances, acute neuropathy, which may mimic GBS. In between the attacks, the patients are asymptomatic. And importantly, the attacks are precipitated by heavy alcohol consumption by numerous medications, many of which are commonly administered in the ICU, such as diazepam, theophylline, and this patient received and barbiturates, which activate the hepatic cytochrome P450 system. In this case, could the patient had episodic psychiatric disturbances explained by AIP triggered by alcohol consumption? Could a porphyric neuropathy have been caused by the administration of theophylline or another medication in the ICU setup? We are not sure. So AIP, what is the electrophysiology shows a reduction in the common compound muscle action potential, an early feature of this disorder. Overall, EPS findings indicate a primary motor axonal degeneration, which caused the weakness. So in this case, A porphyria is ruled out because the absence of EMG activity in two separate studies. Whenever the diagnosis cannot be excluded, urinary porphyrins should be measured. Attacks of acute AIP can be successfully treated with early administration of hematin or heme products. So there are some other causes of rapidly progressive generalized weakness in ICU that includes hypophosphatemia neuropathy, severe renal failure associated neuropathy, motor neuron disease, lead intoxication causing neuropathy, paraproteinemic neuropathy, Lyme disease, and HIV neuropathy. These are all other causes which are also weakened. So that finishes the narrow part of weakness. Now the neuromuscular junction disorders. The neuromuscular disorders resulting from the disruption of this deserves consideration very much because we use a lot of drugs. They can be unmasked in previously undiagnosed cases by medication that are commonly used. Patients with myasthenia gravis or Lambert-Eaton myasthenic syndrome have an extremely high sensitivity to subtherapeutic levels of muscle relaxants, which are commonly used in ICU, and other agents such as aminoglycoside antibiotics and certain antiarrhythmic agents that have an inconsequential effect on the neuromuscular junction transmission in the normal persons. But in ICU, they may cause problems. So, a syndrome of severe weakness seen only in critically ill patients may occur when a muscle relaxant is given for extended period of time to facilitate mechanical ventilation. This often we see in our ICUs. So, a syndrome of this in one retrospective study of 16 critically ill patients who had received vencuronium for at least 2 consecutive days. All 7 patients with prolonged weakness after its discontinuation were found to have impaired renal or hepatic function and high circulating levels of 3-desacetyl vecuronium, an active metabolite of vecuronium. So the paralysis persisted for 6 hours to more than 7 days after the discontinuation of the muscle relaxant. The catch point here is prolonged neuromuscular blockade must be ruled out by studies of RNST in a weak or paralyzed patient who are critically ill, who have been exposed to neuromuscular blockers, and especially if the exposure has been prolonged or if there is a kidney or liver failure. That is the time. So this patient's weakness probably cannot be explained by the neuromuscular junction transmission because the RNST results were normal at both low and high frequencies. Although RNST recorded in distal muscles may frequently yield normal results in case of myasthenia gravis, especially when it is mild. So it is very difficult, however, to explain the degree of weakness in this patient on the basis of deficit in neuromuscular transmission in the face of normal findings on RNST. Obviously, in cases of total paralysis due to complete NMJ blockade, CMAPs are absent. Now that brings us to myopathies. Now we've seen the neuropathies in this case, diagnosed differential diagnosis, neuromuscular junction abnormalities, myopathies. A necrotizing myopathy in critically ill patients who have been treated with muscle relaxants for several consecutive days is characterized by severe generalized weakness lasting for weeks to months, areflexia, normal sensation, occasional ophthalmoplegia, and a marked CPK rise. Some critically ill patients with necrotizing myopathy have been treated with high-dose corticosteroids for asthma. So that is a complication of steroid treatment. So acute myopathy, which is characterized by the loss of myosin filaments, is being increasingly recognized in critically ill patients who have received high-dose corticosteroids in this case. These patients have an acute onset of moderate or severe limb weakness with a proximal predominance and respiratory weakness and a paucity of cranial nerve deficits. So one of the interesting things like myosin myopathy, and acute myopathy is characterized by the loss of myosin filaments, and it is being increasingly recognized in critically ill patients who have received high-dose corticosteroids, as in this case. These patients have an acute onset of moderate or severe limb weakness with a proximal predominance and respiratory weakness and a paucity of cranial nerve deficits. The weakness typically develops over a period of several days, and muscle atrophy may be present. The tendon reflexes are usually reduced or absent. So myosin myopathy is an acute myopathy which can occur in ICU setup. And let us see the characteristics of myosin myopathy to some extent. And see, because we keep coming across so many weaknesses. The critical illness myopathy associated with myosin deficiency, there are some characteristics. It is distinguished from corticosteroid-induced myopathy, which is a slowly evolving myopathy producing a mild to moderate proximal weakness, which has mild elevations of CPK and type 2 fiber atrophy, although the two disorders may have similar underlying pathogenetic mechanisms. But critical illness myopathy, which is associated with the myosin deficiency, like corticosteroid appears to be slowly reversible after the cessation of treatment with steroids. So that is a reversible problem which we can tackle. CPK levels are normal or only slightly transiently elevated. CMAP amplitudes are reduced in proportion to the degree of weakness. There are no nerve conduction abnormalities, and amplitudes of snaps are also not preserved. EMG shows little or no abnormal spontaneous activity, unlike in neuropathies where you have abnormal spontaneous activity. That is critical illness neuropathy. And varying amounts of readily recruited myopathic motor unit potentials can be seen. So, at sometimes both the neuropathy and myopathy can coexist. In some cases of critical illness myopathy, especially when high dose corticosteroids have been combined with prolonged neuromuscular blockade or prolonged inactivity, a combination of necrotizing myopathy and a myosin loss has been observed. If sepsis or multi-organ failure has also developed, the critical illness polyneuropathy may be superimposed. In that case, you have features of both. There are some other causes of acute generalized weakness, that is polymyositis, dermatomyositis, hyperkalemic or hypokalemic periodic paralysis, and various metabolic myopathies and neuroleptic malignant syndrome. But in this case, we are not considering them. So now, after having seen the introduction of this, let us look at the pathophysiology of these conditions. See, the critical illness weakness, the prevalence is about 25 to 100%. There are some important risk factors. That is persistent systemic inflammation, which you can cause by doing a CRP, multi-organ system failure, hyperglycemia, glucocorticoid therapy, neuromuscular blockades, less than 48 hours preferably, should not do more than 48 hours, or will get in trouble, prolonged immobilization, and sedation. One of the important things is sedation. Griffiths et al. Showed that the effects of continuous passive range of motion in one leg in critically ill patients who's on respiratory failure and he was receiving neuromuscular blockade, the contralateral leg in this study served as a control. In the mobilized leg, what happened? The muscle fiber atrophy and wasting were not seen, they're attenuated. One more point which we should consider is the inactivity of diaphragm, which is associated with rapid atrophy and dysfunction, that also will cause to delayed weaning. So there are some female sex is so known sepsis, catabolic state of steroids, multi-organ system failure, systemic inflammatory response syndrome, long duration mechanical ventilation, immobility, hyperglycemia, glucocorticoids, neuromuscular blocking agents. These are all responsible risk factors. So in the critical illness polyneuropathy, motor nerves are affected more than the sensory nerves. Secondary denervation, muscle injury may happen in myopathy. The proposed mechanisms which we discuss in detail are nerve ischemia, nerve microvascular injury, nerve mitochondrial injury, sodium channelopathy, which we'll discuss subsequently. And in myopathy, it is usually primary myopathy. This is a selective myosin loss. Muscle necrosis is less common. Mitochondrial dysfunction, oxidative stress, and sodium channelopathy. These are the causes for critical myopathy. So let's go on now. On the pathophysiology, we'll see various disorders. The atypical Guillain-Barré syndrome is a patient with atypical GBS, a reduction in the amplitudes of CMAPs without abnormal spontaneous EMG activity, which is due to the failure of impulse propagation in the distal portions of motor axons that have remained intact, have continued to supply muscle cells with trophic substances. So if it is a GBS and it's only the nerve conduction that is the large fiber affliction, then the muscle won't atrophy. But in axonal variant, the muscle atrophies because the axon is interrupted and the continued supply of muscle cells with trophic substance is halted. In myosin deficient critical care myopathy, the absence of EMG activity due to the absence of segmental myonecrosis can produce. So, myonecrosis can produce fibrillation potentials in the segments of muscle that have been disconnected from the end plate containing segment. So, this will not be present. The loss of integrity of the contractile apparatus, that is myosin deficiency, explains the weakness, but not the EMG activity. So the pathophysiology continues, and what are the other features of this is the reduction in CMAP. The most important finding is compound muscle action potential. There is a reduction or an absent. The diminished size of muscle cells in the critical illness myopathy, which leads to reduction in the field potentials that are generated by the sum of individual muscle action potentials. The acetylcholine receptors and the sodium channels, which are normally concentrated at subsynaptic sites in the muscle cell membrane, they may diffuse into extrasynaptic regions because of a disruption in the cytoskeleton elements that anchored them in the place. This leads to a reduction in CMAP. So that's a mechanism of reduction in CMAP, which that's because of acetylcholine receptors and sodium channels. They are normally concentrated at subsynaptic sites in the muscle cell membrane, but they diffuse into extrasynaptic regions because of the disruption of the cytoskeletal elements. That's important to know. Further to this, a final explanation is that myopathic cells, although viable, may be unable to maintain a normal resting membrane potential. Even slight reductions in the resting potential can cause marked reduction in the number of sodium channels. So they are reduced through inactivation, which is a voltage-dependent property of these channels, and are thus unavailable for the generation of action potentials. So this phenomenon, which is exemplified by the hyperkalemic periodic paralysis, which in this, a minority of the mutated sodium channels that fail to become inactivated cause the resting potential depolarizations, which is sufficient to inactivate most of the normal sodium channels. So sodium channels play a very important role in the CMAP reduction. So that point should be very crystal clear to everybody, that that's the reason for the weakness. So in fact, the profound, rapidly evolving, reversible reductions in the amplitudes of CMAPs have been documented during the rest period after exercise in patients with sodium channel disease. Similarly, the affected muscles in patients with critical illness myopathy, which is associated with the myosin deficiency, may fail to maintain normal resting potentials and become inexcitable, leading to marked reductions in the amplitudes of CMAPs. So the presence of polyphasic amyoepis on EMG without any spontaneous activity early in the course of the disease is more compatible with non-necrotizing myopathic disorder, that is primary myopathies. So the EMG evidence of myopathy in the absence of laboratory or electrophysiological evidence of widespread muscle necrosis as by the spontaneous activity supports the diagnosis of critical illness myopathy associated with myosin deficiency, which may be confirmed by muscle biopsy. So now if you look at these conditions, sorry, hello, yeah, yes, अभी मैं मीटिंग में हूँ, बाद में बात करते हैं. High dose corticosteroids, they diffuse. What happens if you treat an high dose corticosteroids? Diffuse myofiber atrophy with loss of myosin filaments is characteristic of the acute critical illness myopathy that occurs in patients who are in intensive care units. These are treated usually with status asthmaticus is treated with high dose corticosteroids. There may be usage of neuromuscular blocking agents and other factors which are related to the critical illness may be contributing causes. If these individuals have a pre-existing neuropathy or neuromuscular junction disorder, Then high-dose corticosteroid therapy in the presence of muscle denervation caused by pre-existing neuropathy or neuromuscular blockade may lead to particularly severe form of corticosteroid-induced myopathy. So the problem is high-dose corticosteroids, which results in selective loss of myosin filaments. The skeletal muscle, it leads to a marked increase in the numbers of glucocorticoid receptors in the muscle. So suggests that the denervated muscle becomes especially susceptible to the catabolic effects of corticosteroids because of the increase in the glucocorticoid receptors. So administration of high dose corticosteroids is very important. And so one has to be careful in administering these doses. Or we should be aware that that's one of the reasons for delay in the weaning. So the spontaneous activity, right. So what are the muscle biopsy features which we see? The features that suggest are primary myopathy. And now we'll see what is primary myopathy. Microscopically, there is a marked diffuse fiber atrophy with numerous small angulated fibers. So both type 1 and type 2 fibers will be atrophic with a mean diameter of 28.5 millimeters. Normally is 50 to 60 for type 1 fibers, and 24.6 normally is about 45 to 70 for type 2 fibers. If you examine the toluidine blue stained thin sections, they show disruption of the myofibrillary networks in the mostly atrophic fibers. I'll show you a couple of slides. No inflammatory infiltrates, fiber necrosis, specular change, inclusions, lipid or glycogen accumulation, fibrosis, grouped atrophy, or fiber type grouping are noted in this case. So this is the primary myopathy features. If you do electron microscope examination, it reveals a widespread myofibrillar disorganization with a striking loss of myosin filaments and a relative preservation of thin filaments, and that is actin filaments and jet bands, and the mitochondria are normal. So you can see that skeletal muscle wasting, which you can see in this case, where you can see the wasted muscles here, and you can see the wasting muscles. And possible mechanisms include microvascular ischemia, catabolism, and immobility. I'll show you the now next time. Polyneuropathy with axonal degeneration. You can see the nerves which are axonal degeneration here in this case. The possible mechanisms are microvascular injury with resulting nerve ischemia, dysfunctional sodium channels, and injury to mitochondria. These are the common causes. So in this kind of Freudian section, muscle biopsy specimen, which shows many angulated atrophic muscle fibers. Angulated atrophic muscle fibers. These are normal fibers which are here. There are some atrophic fibers which you can see in these angulated fibers. There are some small vacuoles. They're artifactual. Don't worry about them. This I'll show you the electron microscope picture of this. The electron microscope micrographs will show myofibrillar disorganization, and that's what the striking loss of thick myosin. That is thick myosin filaments, and that is the short arrow. This is the thick myosin filament, and this is a short arrow. This you can see the thick myosin filament is getting degenerated, and the remaining thin filaments, the long arrowheads, the actin elements and jet bands or long arrows. This is jet band, and another one is the myosin, the actin filament. They are preserved. So myosin filaments are across. If you see at the case of our case and the control, you can see the fiber size difference, and which you can see how big and how small are these fibers. They show myosin heavy chains. You see the case and you see the myosin here, the distribution. Fast myosin heavy chains, you can see. So there's a control. The changes in fiber size and expression of slow twitch and fast twitch myosin heavy chains are seen in the patients who are undergoing mechanical ventilation. So now let's look at the electrophysiology. So which we have already, this thing I have showed you. What is it? What are the clinical features? Critical illness polyneuropathy is different from critical illness myopathy. So normal to minimally reduced nerve conduction velocity, reduced CMAP amplitude, reduced snap amplitude also. These are seen in polyneuropathy. EMG may show some spontaneous activity. Okay. In critical illness myopathy, normal to minimally reduced nerve conduction velocity, CMAP is reduced. There is no muscle excitability and direct stimulation and normal snap. So these are only electrical features of nerve, but EMG may show no spontaneous activity here, but spontaneous activity may be present in this case. Okay, so that's another important thing which to distinguish. Let's see the etiology of conditions. Just will revise. What are the conditions which we can come across in ICU for the purpose of learning? Guillain-Barré syndrome, which has got an autoimmune mechanisms. There will be myelin loss, which has got autonomic instability, ascending paralysis, ventilatory failure. Myasthenia gravis is autoimmune mechanism. Bulbar palsy, there are antibodies against neuromuscular junction. Porphyria, porphyrin accumulation with resulting nerve toxicity. It is also axonal neuropathy and autonomic instability, abdominal pain, psychiatric manifestations. Eaton-Lambert syndrome, paraneoplastic, proximal muscle weakness. It's a presynaptic calcium channel antibodies are presynaptic defect and autonomic instability also seen. The reflexes will be absent in this case. ALS has got UMN, LMN signs and bulbar involvement, fasciculations and muscle atrophy. Vasculitic neuropathy, occlusion of vasa nervorum, and this causes paresthesia, numbness. It's a painful neuropathy, and there will be cell and immune mediated complexes, the distal polyneuropathy. And mechanical injury to cervical spinal cord can give rise to paresthesias. And botulinum toxin can have bowel dysfunction, bladder dysfunction, inhibition of the acetylcholine release from the presynaptic membranes, bulbar palsy, descending paralysis, and autonomic dysfunction. So these are very important aspects. Let's see some of them in detail, and we can see how we can differentiate various these etiologies. So if you look at the GBS, there's a frequent involvement of bulbar and respiratory muscles, distal paresthesias and sensory loss. That means basically it's vibration, areflexia, and there are strict laid out criteria. That is Asbury, modified Asbury criteria, dysautonomia in some cases. The CPK is normal, the elevated protein level in the second week, and there is almost pathological dissociation that they may be associated with infection, trauma, or surgery or vaccinations. And acute motor axonal neuropathy is associated with Campylobacter jejuni infection. Here, the compound muscle action potentials are reduced, but there is no conduction block. It has also got quadriplegia with no sensory deficits, areflexia. We already read that critical illness polyneuropathy and acute intermittent porphyria, which I'm not going to. So some of the electrophysiology characteristics are depicted here. Like GBS has got abnormal spontaneous activity in some cases. There will be poor recruitment and rapid firing on EMG, but evidence of conduction block and prolongation of nerve conduction velocities and CMAP amplitude reduction, especially in axonal variant, is more important. In critical illness polyneuropathy and this myopathy also, one important finding is reduction in both CMAP and SNAPs are absent. And these same findings can be seen in acute intermittent porphyria. So now you see the muscle biopsy findings in all the cases are neurogenic changes. How difficult it is to diagnose any weakness, and you can have Lambert-Eaton syndrome, prolonged neuromuscular blockade induced by the muscle relaxants. So, but there are not sensory deficits, normal or reduced reflexes. But if there is renal or hepatic failure, you have more problems. Myasthenia gravis is associated with elevated titers of anti-acetylcholine receptor antibodies, and repeated nerve stimulation test may be positive. Lambert-Eaton syndrome, the areflexia, autonomic dysfunctions, and no sensory deficits, but it's a weakness that improves with exercise, associated small cell carcinoma of the lung usually, and also associated with food poisoning or wound infections by Clostridia bacteria. And there are typical, as I said, the nerve conduction velocity and repeated nerve stimulation tests show abnormalities. So these are so what is the recovery pattern in these cases? And let us see how do they recover. Is there any treatment? Treatment. In patients who require prolonged mechanical ventilation, neuromuscular recovery is typically prolonged and incomplete. 65% show neuromuscular abnormalities, and some may persist for many years. So, general care, what usually happens in ICU, includes a liberal use of sedation and immobilization. For why do they do it? To facilitate interventions that normalize the physiological functions by artificial means. So, what is recommended is there should be a paradigm shift away from this approach called less is more. This is a philosophy for patients in ICU. There are studies to say that Herridge et al. Followed a cohort of survivors of ARDS for 5 years, and after discharge from hospital, the muscle weakness and functional impairment were frequently observed at 1 year. So the recovery from physical dysfunction was incomplete even 5 years after discharge. At the 5 year assessment, the results of 6-minute walk test were still only 70% of the predicted results. So, how do we tackle this problem? You optimize ICU care. Early physical activity, despite of the severity of illness, has to be encouraged. The discontinuation of deep sedation is a critical first step in optimizing patient activity and awareness. And we keep coming across the deep sedation in all the cases without knowing what harm we are doing. But we, with impunity, we go on putting them on deep sedation. So the De Jong et al. Noted that use of sedation algorithm designed to allow patients to be more alert was associated with a 50% reduction in pressure source, and presumably because of reductions in sedative related immobilization. Needham et al. They reported changes in ICU care to reduce sedative use, improved the hospital activity levels in a group of patients in the medical ICU. So what are therapeutic interventions? You do a good glucose control and early mobilization. There are methods of doing early mobilization. Burns and Jones described a walker device which is designed for the patients who require mechanical ventilation. A new concept has developed, which is ambulation during mechanical ventilation by using a cycle ergometer, and that is very phenomenal. It's a passive movements of the legs with the help of the bicycle ergometer. Bailey and colleagues reported on mobilization in a large cohort of patients who required mechanical ventilation. The activity was encouraged as soon as the condition of the patient was hemodynamically stable with a modest ventilatory settings like FiO2 less than 0.6 and PEEP of less than 10 cm of water. Ambulation, even during mechanical ventilation, was feasible with few adverse events. So don't be afraid to address. So the device removal or deterioration of vital signs are not going to happen. Barton and colleagues reported the benefit of a cycling exercise session with the use of a bedside cycle ergometer, which I was mentioning, which is attached to the foot of the bed. The ergometer could provide passive range of motion exercises for patients who are not sufficiently alert to participate and activate. So these people can be helped. It's a very interesting aspect that to improve our ICU care, we have to mobilize them very fast. So this is a very Morris and Schwickert et al. In 2009, they have done a study on this immediate mobilization strategy that has led to a near doubling of functional independence at hospital discharge, despite the fact that hospital length of stay did not differ, but they were functionally independent at the time of discharge. So what are the common barriers to early mobility? Failure to awaken from sedation. The first step is less sedation should be less. So if but problem is if you stop a sedation agitation, then you have to. And sometimes it so happens the patients will be sent for diagnostic tests. Then also the delay will be there in ambulation. So a lot of times they will be better than. So you can see that measurement of what I was telling, that adaptation to intensive care environment, it is ATICA based sedation analgesia algorithm. It is measured every 3 hours, except during the night, the patients with satisfactory consciousness at the end of the day. So what they do is they keep on awakening the patient, and the algorithm is given, and you have to reduce most of the sedative drugs and see that the patient awakens and is. So I conclude by saying that many survivors of critical illness have considerable functional impairment due to ICU acquired weakness. The recovery is often slow and incomplete in such patients, particularly those who are elderly. There are risk factors such sepsis, hyperglycemia, which may require insulin therapy, delayed mobilization, because early mobilization of patients in ICU, although not a traditional approach, showed an evidence-based strategy evolved, which reduced the reconditioning and dysfunction so commonly seen in survivors of critical illness. And minimizing the use of sedation is very important. There should be a multidisciplinary care with occupational therapists and physiotherapists. All the preliminary data are encouraging. More research clearly is needed to determine whether the benefits of mobilizing patients in ICU are sustained after hospital discharge. We have an algorithm after this. I have an algorithm which can be seen, right? So what happens in this is, if you have got a uh, interrupt the use of sedatives and analgesics, the patient awakes and able to follow instructions. Okay, then I will assess the MRC score. Normal findings, physical and occupational therapy is advised. If the score is less than 48, that is MRC score indicates symmetric weakness. Serial examinations, physical and occupational therapy. No change in condition deterioration, then you do nerve condition studies and EMG and muscle biopsy. If there are focal deficits in peripheral neuromuscular system, also you require to do nerve condition studies and EMG and muscle biopsy. The deficit in the central nervous system, maybe MRI brain and EEG will help you CSF. If patient is awake and able to follow all the instructions, the answer is yes is this. If it is no, continue to withhold sedatives or analgesics. Patient remains unresponsive, then also you have to do CT or MRI brain. So the other said, where patient is okay and is you have assessed the MRC score and you did a nerve conduction study and EMG, then the peripheral nerve conduction velocities show no demyelination, reduced amplitude, as I said, of CMAPs and SNAPs, that is critical illness polyneuropathy. If there is reduced amplitude of compound muscle action potential, but selective loss of thick filaments in muscle biopsy and muscle necrosis, that is critical illness myopathy. So it's a very tough subject in ICU with so many limitations. Still, we try and resolve the issue, and let's hope that we will be successful in getting cycle ergometers into the ICU, so that a passive cycling exercise can be done. The patient should get less sedation. Neuromuscular blocking agents should be very infrequently used and should not be kept for long, because as you've seen, the effects are very prolonged. And I think with this, I have completed my talk. And if there are any questions, and we can have one or two questions if somebody is interested to ask. I hope the at least some part of the talk is related to, there is a nerve problem, there is a neuromuscular junction problem, and also there is myopathy. So there are differences here, but we should be able to diagnose. And the only thing is prevention, and the prevention includes less sedation, less neuromuscular blockade, early mobilization, strict control of blood sugar. These are the important issues that emerge. So if you people are clear and there are no questions, if you want to unmute, you can self unmute and ask questions, or you can type if you want, so that I can answer. Wait for a minute or so for you to respond. If there is no response, okay, that's right. So this is a week of World Brain Day, that is we celebrate on July 21st. I'm happy to take a class in this week and to commemorate the World Brain Day. Okay, then it's good night. Thank you very much.